Welcome to the lecture on basic electronic fetal heart rate monitoring. Your learning objectives for this course content mean that you will be able to interpret and utilize the components of a fetal heart rate tracing. You'll be able to recognize what that information is telling you. With that information, you're going to prioritize and implement appropriate interventions so that you can most effectively improve your uterine placental perfusion, which is another way of saying we're going to get more oxygen to our fetus. Lastly, you'll be able to evaluate non-reassuring fetal heart rate patterns and change up your interventions to use the tools that are going to get the most oxygen to that fetus the most quickly. Electronic fetal heart rate monitoring is a system that involves usually this little machine over here. You can see you can have the information printed out on a long strip of paper. There is also a computer up here. Most often in clinical, you're going to see nurses using the computer here and not printing out paper. The intent of intrapartum fetal surveillance, meaning fetal surveillance during labor, is to assess uterine activity, contractions, to assess the fetal well-being, how your baby is responding to the contractions, and to assess the response to those contractions so that you can make appropriate physiologically based clinical decisions. So what does fetal monitoring tell us? Or basically, why do we do this? By seeing how the baby's heart rate changes, we are able to assess our status of fetal oxygenation. This also lets us know the acid-base status of the fetus. Go back to your block 2, remember your blood gases? This is the kind of information we're talking about here. That acid-base status tells us the ability of the central nervous system to regulate the fetal heart rate. If our central nervous system is working well, we expect the fetal heart rate to do certain things. If it does not, we question the oxygenation of the fetus. By monitoring, we hope to prevent hypoxia and asphyxia, which can lead to some bad things. When adequate fetal oxygenation does not occur, remember metabolisms proceed along with an anaerobic pathway that produces acid, such as lactic acid. This acid uses up buffers in the fetal blood system and eventually can result in metabolic acidosis, which changes the fetal pH, which leads to fetal distress. Part of the challenge of fetal heart rate monitoring is that very small changes in pH may cause significant damage in fetal function and outcome. However, not every baby reacts in the same way. Some babies have more of a buffer system than others. In order to understand fetal heart rate monitoring, you need to have a basic understanding of the physiology between the placenta and the fetus. I strongly encourage you to watch the video if you haven't yet, posted in the Canvas course under the lecture videos. The little Cons Academy video that explains this very well in 10 or 15 minutes. Remember, the oxygen pathway goes from the maternal lungs to the maternal heart, which spreads through mom's vasculature, which brings this blood to the uterus. After the oxygen combines with the fetal hemoglobin in that passive transportation in the placenta, the oxygenated blood is going to return to the fetus via the single umbilical vein and umbilical cord. Remember that maternal and fetal blood don't mix. Oxygen and nutrients are delivered, and carbon monoxide and waste are removed via passive diffusion. It also helps to remember that in a fetus, you have the vein that is taking oxygenated blood to the fetus and two arteries that are taking carbon dioxide and waste away. It's reversed in a fetus. With this in mind, you can think about how maternal conditions are going to impact the amount of oxygen transported via that placenta. Some maternal conditions, most commonly that can impact this, are maternal hypertension. You have constricted blood vessels, you have decreased oxygen. You can also have hypotension, sometimes caused by loss in blood volume, sometimes caused by a sudden drop in blood pressure that decreases maternal circulation, That's going to impact how much blood is getting to your placenta, which is going to impact your fetus. Anemia, not an uncommon condition in pregnancy, is also going to impact how much oxygen is transported in that red blood cell vasculature. There is also many common conditions that can damage vasculature. Most commonly in our society right now, diabetes. Think about the long-term complications of diabetes and how that is all traced back to damaged vasculature in the body. If you have damaged vasculature, your transportation system between your placenta is not going to work as well. Other potential ways that the fetal oxygen supply can be affected is alterations in the fetal circulation itself. These can be congenital abnormalities, things that do not develop correctly as the fetus grows, or they can be abnormalities in the cord itself. Occasionally you will have a fetus impacted with a cord that only has one artery and one vein, thus impacting the circulation. Consequences of uterine hypoxia and asphyxia can be severe. It can lead to cerebral palsy. Remember, uterine hypoxia and asphyxia can happen at any point in the pregnancy, not just labor itself, but in the second and third trimesters. Can also lead to decreased oxygen to the brain, which is going to cause problems like potential epilepsy, can cause chronic brain impairment. Respiratory distress syndrome is more likely to happen in babies who have had episodes of hypoxia because the lack of oxygen is going to impact the hormone production in the lung development, which means their lungs aren't going to develop normally, so they will have problems breathing after birth. Remember, just like in an adult, what are the first organs to go when the body is trying to spare oxygen? Kidneys. So if you have a fetus that is born with renal damage, it is probably because there's been some hypoxia at some point in the pregnancy or the labor process. Necrotizing enterocolitis is a similar cause. If you have intestinal tissue that was not well supplied with oxygen, that intestinal tissue can decay and literally die. Remember, your fetus does not use that tissue until after they're born. So once the fetus has been born, you have a newborn that tries to process food. The food does not process well. You have that dead tissue, and their little bellies start to swell. This is one of the more common concerns in NICUs, especially with preterm babies. So the object of fetal heart rate monitoring is to reduce the mortality and the morbidity by hopefully ensuring that all fetal hypoxic insults are identified in time to allow renewal of the baby, or maybe alter the reason for the lack of oxygen. Maybe we can fix it and continue with the pregnancy or the labor process. Remember that lack of oxygen in the blood is hypoxemia. Lack of oxygen in the tissue is hypoxia. When we have a lack of oxygen in the tissue, this leads from aerobic to anaerobic cellular metabolism, which produces lactic acid. The lactic acid uses up the buffer in the baby system, also the bicarb, leading to metabolic acidosis. Continued metabolic acidosis can lead to the things listed in the slide. Now that we know why we're doing it, let's talk about how we're going to do it. This is a picture of the monitors of an external fetal monitor. You have here the TOCO transducer, which usually is simply called the TOCO. You're never going to hear anybody call it anything else. Below it here, you have an ultrasound device that uses Doppler ultrasound to pick up the motion of the fetal heartbeat. It translates that information through these lines to the machine, which then gives you a printout on your computer screen. Placing the devices is something that can be very quick or take a lot of your labor and delivery nurse's time. Your TOCO on the top belongs on the fundus of the uterus, which is basically the part where the most muscle is, which is the top of the uterus. Keep in mind that your gestational age is going to impact this. A full-term baby, the uterus will be up pretty high, close to the rib cage. If you had a smaller baby or a preterm baby, your TOCO is going to be placed a little bit lower. This means you have to palpate the uterus to find the best spot to pick up those contractions. The ultrasound device, in order to pick up the fetal heart rate, in a perfect world, will be in about the lower left or right quadrant. You can see how here we're aiming to go basically through the baby's shoulder so that that device can pick up those Doppler ultrasound waves fairly easily. Babies move, they wiggle. If you have a breech baby that's the other direction, you may be searching for that fetal heart rate for a little while. A close-up picture of your devices. Your ultrasound device here, in order to pick up that heart rate, is going to require the ultrasound jelly, also known in the highly technical term of goop. You're going to take your goop, you will cover this little device, you will then place it to try and find your heart rate. Remember, the TOCO, the contraction monitor, does not require any ultrasound jelly. Don't put anything on this. If you look at the TOCO carefully, you can see there's a little pressure-sensitive button in the middle. They don't all look exactly like that, but they're very similar. That pressure-sensitive button is what gets pushed when that uterus tightens up, the muscle contracts and gets hard. This is how the external monitor will sense that a contraction is happening or not happening. An external contraction monitor does not give me an objective measurement of how strong the contraction is. It simply tells me when the contraction starts and when it ends. Keep that in mind. There is also a way to use internal monitors to give you similar information. If you need to pick up a fetal heart rate, your baby is moving quite a bit, there's a lot of maternal tissue between the ultrasound monitor and the fetus. We like to call it fluffy in OB terms. If you have twins, there are many things that make it difficult to continuously trace that fetal heart rate. So we may need to use an internal monitor to do this. A fetal scalp electrode, also called an FSE, is placed directly on the baby's head via a vaginal exam. This allows us to get continuous information. We also have an intrauterine pressure catheter, an IUPC, which is an internal contraction monitor. An RN, after she's been trained and certified, can place a fetal scalp electrode, but you must take a midwife or an obstetrician to place an IUPC. The IUPC does have an advantage in that it can tell us objectively how strong the contractions are. It measures the strength of that uterus contracting in millimeters of mercury. So the printout will give you that information. Why do we want to know? Sometimes in labor, we want to know if the contractions are strong enough to be doing what they should do. If we question that, an IUPC is a way for us to get that information. So one advantage, it gives us a little more information about contractions. It is easier to get a continuous fetal heart rate tracing on our fetus because the baby shifting and moving doesn't impact your internal monitor. Disadvantages. Looking at the picture, think about what you have to do. Keep in mind that your fetus is usually surrounded by a bag of amniotic fluid. As you can see, this isn't going to go through that membrane, so you must rupture her bag of waters, or maybe it's happened on its own, before you can use these devices. They are also a more invasive monitoring technique, so you're going to have an increased risk of infection. If you look at this IUPC, intrauterine pressure catheter, you can see how you might accidentally poke something on one side or another, or if you have a placenta right up here and you go too far and poke your placenta, you could have a significant bleeding episode from that. Very uncommon for that to happen, but those are disadvantages of the internal monitoring. We do not use internal monitoring on premature labor patients. If you had a patient with any type of blood-borne contagious disease, such as HIV, you're not going to do that. Twins, sometimes we'll use them, sometimes we won't, depends on if they're term or preterm. This slide is just a reminder of your external monitor versus your internal monitor. Remember, this is a TOCO Doppler ultrasound, whereas this would be a fetal scalp electrode and an IUPC or intrauterine pressure catheter. Sometimes you will only use a fetal scalp electrode and leave on an external contraction monitor, or vice versa. Just because you're using internal monitoring doesn't mean you have to use both types of monitor. You will change it up depending on what the situation calls for. Remember that the intensity of contractions is only measured objectively if you have an IUPC in place. If you do not have an IUPC in place, you're using a TOCO, how do we tell how strong the contractions are? By palpation. This is subjective, but it gives us a good idea. If that hard muscular part of the uterus at the top, the fundus, feels like the tip of your nose, touch your nose right now. Feel how it's kind of soft, has some give to it, but it's firm underneath. There's a mild contraction. Touch your chin. You have a little bit of tissue to go through, but underneath it feels much firmer. That's a moderate contraction. Touch your forehead. There's no give whatsoever. It's firm and hard right away. You're palpating her fundus and it feels like a forehead. That's a good, strong contraction that is probably more likely to be changing a cervix and moving the labor process along. In order to assess your patient, you must use your hands. You have to touch, you have to feel. Electronic fetal heart rate monitoring began to be commonly used in the 1980s. As we discussed, the intent was that we would catch every hypoxic episode and be able to prevent any damage during the laboring process. Or perhaps use it to screen babies during the pregnancy and pick up those fetuses that might have issues before labor even begins. We have used electronic fetal heart rate monitoring for 30 plus years. Evidence-based studies started being done with long-term research about 10 years ago and found something fairly surprising. In several large-scale randomized controlled studies, they found no difference in fetal outcome when we used continuous electronic fetal heart rate monitoring. There was a significant increase in C-sections, but there was no corresponding decrease in fetal cerebral palsy or brain damage or any of the long-term consequences of hypoxia. This makes us pause, think about our evidence-based medicine, and realize that it's a little bit more complicated maybe than we first realized. So in the meantime, we've been talking about how else can we use the best of fetal heart rate monitoring while avoiding some of the disadvantages. Continuous fetal heart rate monitoring does keep mom fairly limited in her mobility. If we use internal monitoring, we have the additional risk that we talked about as well, not to mention the expense. There is a type of monitoring called intermittent monitoring I'm going to briefly mention in case you might see it in clinical. Different facilities use this more often than others. You're less likely to see it at Banner Gateway, for example, than you are at Mercy Gilbert. Just depends on the culture of the facility you're going to. Intermittent monitoring can be done a couple of different ways. We can use the external fetal heart rate monitoring equipment, but only do it for example, 20 minutes out of every hour. Gives us an example. Making sure our baby seems to be okay, catching anything that doesn't look great, while still allowing mom to get up, get in the shower, walk around the unit. Another type of intermittent monitoring is simply using a Doppler ultrasound. As you see the picture right up here, they use this Doppler ultrasound, find your fetal heart rate at least 1 minute before, during, and 1 minute after the contraction. You listen to that fetal heart rate continuously. Below is a table from your text that gives you examples of approximately how often you would do this. Some advantages to intermittent monitoring: considerably frees up your mom's mobility. She's not attached to things, she's able to move around, she can get in bed, out of bed, in the shower, wherever she feels most comfortable to be. Disadvantages to fetal heart rate monitoring: it's not continuous. We can't always get a good baseline, which we'll talk about later. However, in several randomized controlled studies that compared intermittent auscultation with continuous electronic monitoring, and both low-risk and high-risk clients, there was no difference in the intrapartum fetal death rate. However, there's a trick to this. In each of these studies, the nurse-client ratio was 1 to 1. Not every facility has one labor nurse to one patient throughout her entire labor. This suggests that adequate staffing is essential if you're going to come away from continuous fetal heart rate monitoring. When we are using continuous fetal heart rate monitoring, which is far and away the most common thing you will see with your patients who are in labor, this is what you're going to be looking at. This top tracing here represents your fetal heart rate, so that's where your baby's heart rate is. Bottom tracing here are the contractions. So here is your Doppler ultrasound. Here's the results from your TOCO. When we're looking at the contractions, how do we count them? There's a lot of misinformation about this out in the community. When we teach patients to count contractions, what we want them to do is to time their contractions from the beginning of one to the beginning of the next. So I'm going to go back here momentarily. Here's the beginning of one to the beginning of the next. Here, beginning of one to the beginning of the next. On the paper, dark red lines equals 1 minute. So this contraction would be 1, 2, 3, 4, 5 minutes apart and 1 minute long. The duration is how long the contraction lasts. The frequency is beginning of one to the beginning of the next. This lets patients count their own contractions, for example, if they're trying to rule out preterm labor at home, or on the other end, when it's time for the baby to be born, but they're wondering if it's quite the time to go to the hospital yet, counting contractions is a big part of making that decision. Why do we care? Uterine perfusion significantly changes during contractions, and the stronger the contraction, the more impact it has on that uterine perfusion. As that contraction begins, that whole uterus is squeezing. The uterus is squeezing on the placenta. It's giving your fetus a great big hug. It's also squeezing that umbilical cord. So that's going to impact circulation as the contraction gets stronger and stronger and stronger. If it's a strong contraction at the very peak, there is no blood flow going into and no blood flow coming out. Contraction slowly fades away. Our circulation gradually comes back. So at this peak of the contraction, our fetus is not getting oxygen. The good news is our fetus is designed to cope with this. A fetus has significantly higher hemoglobin levels than you and I do. They have, as we previously mentioned before, a buffer system built up to protect them for this. Fetal heart rate monitoring is basically to make sure our fetus is handling contractions well. If we're seeing if our fetus handles contractions, we have to be able to accurately assess and quantify the contractions. When you're looking at your fetal heart rate monitor, it's a big picture, both the fetal heart rate and the contractions together. Don't get so caught up on a heart rate, you're not looking at the contractions.